can't think of anyone better to give the next topic, which is comparing competitive and recreational athletes, how we take care of them, than Dr. Cindy Chang. Cindy's was the head team physician at Cal Berkeley for 14 years. She's been chief medical officer of the U.S. Olympic team in London, so the whole thing. She's got pictures with LeBron and everybody. And now she's helping lead a lot of our efforts with youth athletes in the East Bay. She works at a Berkeley still, and is working with Children's Hospital Oakland with our Sports Medicine Center for Young Athletes. So she's an amazing speaker if you've heard her talk, but her voice is a little bit off. So we'll take it easy on her here. So thanks, Dr. Chang.
Good morning. Thank you, Dr. Luke. Honored to be here again. It's great to see some familiar faces in the crowd. So I'm looking forward to sharing some information. It's kind of a fun talk. So I think this talk is really going to emphasize the importance of being part of a team, a medical team. All right, this is my disclosure slide, and you can see the cartoon, which I thought was quite funny. So our objectives today: discuss the possible differences that would define a competitive athlete from a recreational athlete, and describe possible similarities and differences in the management of injuries in a competitive versus recreational athlete. So when I was asked to do this talk by Dr. Luke and Dr. Center, I really wanted to think about how I wanted to present it to you. And so what defines a competitive versus recreational athlete? That's the first question, if we're going to decide that. So let's think about that. So if we go to Merriam-Webster, who almost 200 years in existence, the competitive, what is the definition of competitive? Characterized or based on competition. Oh, well, that doesn't help. So let's look at competition. So it's rivalry. Okay, and then if you look down below, it's a contest between rivals. Okay, gymnastics competition, for example. What's recreational? Again, relating to a characteristic of recreation. Okay, let's look what recreation is. What's a definition of recreation? A hobby. Okay, a means of refreshment or diversion. So let's interpret that then. Summarize, competitive is relating to or characterized by competition, and competition equals a rivalry, whereas recreational is relating to a characteristic of recreation, so it's a hobby. So that could be a way we could define it. We could also define it based on these factors. Age. The younger they are, if they're really young, if they're 8, then maybe it's more recreational than competitive, maybe. Travel distance for games. How many people are schlepping their kids all over the place to play one game? You're driving further distance to and from than the duration of that game. Is that it? Versus everyone playing on the local Little League field. Practice hours per week, 4 hours to 6 hours versus 18, 14. Does that make a difference? Coaching expertise. How many of you guys have coached your kids' sports activities, right? Versus a professional coach that you pay to coach your teams. Or as we go NBA level, right? Those are obviously coaching, more expert coaches. Level of play. So when I talk about that, is it NCAA? Is it Division I versus Division III? Is it level of gymnastics, right? Early level 3 versus level 8, the level of play. One sport specialization. If you've decided to devote your life to this sport, does that make you a competitive versus recreational? All comers versus tryouts. Everyone can join the team. Just show up, we'll find a place for you on the cross-country team, versus you have to try out. Level of commitment. So that's not only the level of commitment of that athlete, the level of commitment of their support team, including parents, etc., spouses, level of commitment financially, how much you're paying for this. And the goal. Do you want to crush them? I mean, what was the goal? You're going to get that trophy? Everyone get a participation trophy? What is the goal of that sporting activity? The fact is, we don't know. It's really hard to define, but those are all the factors that come into our mind when we're talking about how we're going to work with someone who's been injured. So, for example, here's a clinic intake form for a soccer player with anterior knee pain. And we do these intake forms. And this is the part that we ask is what sports activities to participate in. So this sport is soccer, semi-pro, 20 hours a week, 48 weeks a year. So they've clicked a lot of those boxes, right? Are you kidding me? This is what I said to him. 13. Such as sports. That's another lecture we'll have sometime. So what about performance characteristics? Are there something that we can use to define elite versus recreational athletes? So if you look at a study, Lorenz did kind of a review of this in Sports Health. Elite endurance athletes. If you look at elite endurance athletes and how they define elite is level of play, higher level, Division I, recruiting, that type of thing. No single characteristic has been defined as a main predictor of performance. However, these elite endurance athletes consistently test higher than the non-elite athletes in running economy, anaerobic threshold, and VO2 max. So you can do studies on them and see. And in endurance athletes, anthropometric characteristics correlate performance. And this is what can get dangerous when we talk about athletes that start to develop eating disorders or they're really worried about their lean body mass, because it does show that the mean percentage of body fat for elite male and female runners combined is approximately 8%, whereas it's 10.7% and 12.1% for the good and average runners, okay? If you look at elite anaerobic, the field and court sports, definitely the elite are more powerful and explosive than their non-elite counterparts. So you can do some type of testing to see that, but do we want to do that on every patient that we see? No. So then, is there a difference in the management? So now let's talk about management, because that's where we get involved as clinicians, right? So let's talk. We're going to talk about 3 cases. First one's a shoulder injury, the second midfoot pain, and the third an ankle injury. So here's case 1. Asterisks are there because we're not going to define. A blank-year-old blank football athlete participating at the blank level landed awkwardly on his left shoulder, unable to continue playing. Your initial sideline exam under the pads, normal sensation on light touch, distal strength is intact, pain with any attempt at active shoulder range of motion, decreased strength with pain on testing when arm is at the side, because he doesn't want to lift his arms up, tender along the left anterior chest wall, clavicle, AC joint, and you palpate and you get some swelling over the mid to lateral aspect of the left clavicle. So you send him for x-rays, and this is what you see, okay? So we've got a displaced mid-shaft clavicle fracture. When is the earliest that you would allow return to play? Now, I understand. Again, I said this is a fun lecture because you may not be managing this, but let's just think about this because you may know, listen, your healthcare providers, you're going to get a phone call from Aunt Sue, whose son, hurt his clavicle, and she's going to send you a picture. So this happens to us all the time, right? So when's the earliest that you allow return to play? Now, let's add this in. Let's say that the decision was made by the consultant, orthopedic surgeon, to plate it, and this patient is greater than 18 years of age. Now, when is the earliest that you would allow to return to play? So let's vote on that. I don't have to hit anything, John, do I? I'm not sure if I have to hit anything. Do I, John, have to hit anything? Oh, it's counting. Okay. Oh, there we go. Sorry. Oh. Okay, so the majority, well, it's nice. This looks like the bars for a cell phone. So 10 to 12 weeks. Most of you guys said 10 to 12 weeks. Okay, let's take a look at this. All right. The Canadian Orthopedic Trauma Association did a really great multi-center randomized level 1 evidence, a really great study. And they looked at acute, closed, completely displaced fractures, just like what I showed you. 67, surgery with a plate. 65, no surgery with a sling. Union, radiographically, 16 weeks for the surgery versus 28 weeks for no surgery. Non-unions, higher than no surgery. Symptomatic malunions, higher, 14% versus 0 in the no surgery. Complications, of course, higher, 13% more in the surgery because of, here are the complications: hardware, wound infection, mechanical failure. At 1 year follow-up, there's a greater satisfaction in shoulder function appearance in the operative group. These were not defined as athletes. Here's another study, 2011. 0 non-unions in an operative group versus 8 in the non-operative group. And that was in 73 active patients, I say active, ages 20 to 50. Again, malunions, higher when you don't operate. Constant shoulder scores, that definition, this is what they give their patients, significantly better for operative group at all the follow-up visits. They were happier, less pain, better function. 6 operative complications, all related to this plate. There was a systematic review and network meta-analysis of 22 randomized clinical controlled trials done by Axelrod. He found that surgical treatment did not increase functional scores that were clinically important. Union achievement was lower in the patients treated non-operatively, however. So the difference is 89% versus 96.7% for those that were operating. And it was significantly, statistically significant for that, okay? So surgery does mean that you're gonna have better union. What about some cases? Here's a case that was presented. 23-year-old male college football player, so these parameters were defined. After surgery, returned to full contact at week 5, full competition at week 6. Pretty early, earlier than what you guys voted on, right? Retrospective review of 19 NFL, we would probably say that these are elite athletes, right? Same thing. If they were non-displaced, they managed them. Non-operatively, they healed in 7 weeks. But those were displaced that were treated non-operatively, 3 out of 7 healed at 13 weeks, okay? 4 out of 7 refractured within a year. So they were out again. Not only were they out of football for 3 months, then within a year they fractured again. 6 out of the 13 that were displaced, they were treated surgically. They healed in 8.8 weeks, and 3 returned to play the same season. And that was something that you heard Dr. Center talk about, is in season, out of season. Sometimes those decisions are made based on that. Here's some case series. Again, 30 out of 30 returned to sport at 83 days. 7, less than 6 weeks. That's 23% returned less than 6 weeks. Those that had surgeries, these are all that had surgeries, and 2/3 less than 12 weeks. So most of them, right, within 3 months. 4 minor complications, and you can see the complications listed there. Another study, 53 out of 54 returned to sport at 68 days, and you can look and see 70% less than 6 weeks, vast majority 6 to 12 weeks, okay? And these were the major complications that are listed below. So there are complications. Look at that one, extrinsic compression of the subclavian vein. Not good, right? And then hardware removal because it bothers them. And then this is the last study, 23 studies, 8 prospective cohort studies. So these are all really good studies. But again, if you look, if it's operative, mean time to return is 9 weeks. We didn't talk about the nail. You can put a nail in there. That's what Lance Armstrong had when he fractured his clavicle. Mean return time is the same, weeks, but the re-intervention rate, having to go back in there to take out that screw, 67 to 100%. And in conservative management, that return rate was 21%. So look at the difference, 9 weeks to 10 weeks versus 21 weeks. Okay, so in summary, surgical fixation of displaced midclavicular fractures decreases non-union and symptomatic malunion rates and results in earlier return to function and play. That's kind of the summary of all these great studies. 6 to 8 weeks is the answer. Appears to be the earliest, safest return to play in a contact collision sport after an ORIF with a plate. And the athlete certainly needs to be informed. Informed consent. They need to be informed of the risk. And even though you may not be a surgeon in this audience, you will be asked these questions. So what's some additional questions about this case? What's the optional treatment option for fractures in a competitive athlete? So if we look at this question, We should ideally, in these randomized controlled trials, use athletes participating in non-contact versus contact sports. We know that makes sense. And data collection should not just be at 1 year or 18 months, but it should be more frequently. But what's the incidence of poor outcomes after too rapid return to play? We need to collect that data as well and talk to our patients about it. But what if this was the x-ray? So what's the difference with this x-ray and the first x-ray? Well, the first x-ray, I could have hid the physes because I didn't want you guys to know. But in this case, we're dealing with a kid. See the open growth plates, okay? Is this any different with the child? Pediatric population. So let's look. Adolescent clavicle non-unions are incredibly rare. So 9 pediatric hospitals, their data was surveyed over 10 years, only 25 non-unions were reported, okay? Only 25 non-unions, mean age 14.5 years. And if you look at Gau's systematic review and meta-analysis of 12 studies that was just recently published, looked at 500 patients, average age again was 14, both operative and non-operative, excellent rates of union. But the operative management, faster return to activity, better, superior consent scores, the shoulder scores, yet higher rates of complication, okay, mainly related to the prominent of the plate. Now think about that. These are kids. Are they competitive? Are they recreational? Is surgery worth it? Here's a retrospective review that was in 2018. Complications after plate fixation. 36 patients were evaluated. All the fractures healed. You can see that average time to return to activity, their complication rate was quite high, 43%. Okay, and this is kind of the major ones there. Overall post-op complication rate was 86% for like skin prominence, for example, skin infection, etc. That's pretty high. And then a retrospective review. This was using intramedullary flexible nails. I put these pictures in so you could see how they actually do it. It's a tough procedure to do. You have to pull it up. You can see how displaced it is, and you have to use these clamps to align it to be able to put the screw in. And it's technically, I think you have to be very good. They only looked at 7 patients, average age, again, 14 and a half years old. Sports and full shoulder activity at 8 weeks with that intramedullary nail. 4 out of 7 needed that implant removed, however. If you talk to Dr. Pandya, he's one of our pediatric orthopedic surgeons who will be speaking at this conference. I asked him, and he wrote a paper about his preferred indications. Plate fixation for collision athletes 14 years and above who have injured their dominant hand. Slings for 7 days for physical therapy, then physical therapy is started. Sling is DC at 6 weeks post-op. And this is for any injury. If they have full range of motion, full strength, equal to the other side, and radiographic healing, he lets them return to full contact. If you manage them non-operatively and you put them in a sling, the sling is on for 40 weeks, and then you start PT. No contact sporting activity for 3 months. And it does take a longer time to heal. Okay. All right. Let's go to our next case, midfoot pain. You've got a runner running at some level, comes to your clinic with greater than 2 weeks of midfoot pain, no trauma, cannot keep running, has an important race in 4 weeks. Important is in the eye of the beholder. And on exam, tenderness on palpation over the navicular bone. Okay, you guys can see those slides. You are her second opinion. She has her MRI films with her. She trusts you. You're her primary physician. Diagnosis, navicular stress fracture. High risk stress fracture. Why? Because the central third is very poorly vascularized, with slower healing and a higher risk of going on to a complete fracture or non-union. And on this MRI, you can see that edema, right, in the navicular bone, all right? There's an arrow there. Her first opinion had said, you know what? I know this race is important to you, so let's do this. Let's put you limited weight bearing as tolerated, and you can go into a cam walker for everyday stuff. And then take it off, and as long as you tape, arch support, you can train. And we'll follow you every 10 to 14 days with x-rays and make sure it's not getting worse. Okay? This is true. How would you manage an athlete after diagnosis of a navicular stress fracture? Let's assume that the first orthopedic specialist appointment is 4 weeks out. Right? So NWB means non-weight bearing, so you're going to be using crutches. LWB is limited weight bearing. ORF is surgery, open reduction internal fixation, followed by non-weight bearing or limited weight bearing. Okay. All right, so 38% said non-weight bearing for 6 weeks, and 34% said limited weight bearing is tolerated for 6 weeks. Let's talk about this. All right, so Torg, Philadelphia, 1982, did a retrospective review, multi-institutional study of 21 cases, just 21 cases, and really, thank you so much, Charlie. And really, the interval between symptoms and diagnosis averaged 7 months. So my first thing to you is do not miss this injury. Midfoot pain, no trauma, chronic, weight bearing, running, etc. Don't miss this diagnosis. So it was diagnosed with a bone scan, a tomogram. How many of you guys know what a tomogram is? Right? Right. Anyway, 1982. So this is how he managed them. Non-weight bearing cast for 6 to 8 weeks, 4 of them in a weight bearing cast, 5 limitation of activity and continued weight bearing. 1 was displaced, it was surgery. And again, this is multi-institutional study, retrospective review. He didn't manage all these, but this is a whole bunch of people. So if you look at this review, 10 of them in a non-weight bearing cast for 6 to 8 weeks, all of them healed. Okay? 4 in a weight bearing cast, those 5 that were limitation activity, like don't run anymore, but you can continue to walk on it, all had pain with delayed union, non-union, or recurrence of fracture. Okay? Chang did a study 10 years later, a prospective review of 86 cases, non-weight bearing for 6 weeks, 86% returned to sport at 5.5 months. Limited weight bearing is tolerated, only 26% returned to sport by 6 months. And 90% who had unsuccessfully used limited weight bearing as tolerated, then you put them back in a non-weight bearing for 6 weeks, then they did well. How about Saxena? Did a retrospective review of 22 cases, and again, if you operated on this 9 patients, they returned to play in 3 months. If you treated conservatively, in his hands, 4 months. And he classified the type of navicular stress fractures. Because in classifying them, 6 years later, did a prospective review, and if he managed them well, depending on the type of classification, they all returned to activity in 4 months, conservative or with surgery. Torg came back in 2010 and did another study, and this is a meta-analysis. Again, looking at how to manage them. If you look at the bottom, 96% non-weight bearing cast immobilization for 6 weeks, they all healed. 96% healed. Return to play was 5 months. 82% treated surgically, return to play, they healed, return to play 5 months. So better healing rate with this than with surgery. And return was almost a little bit longer, surgically. And again, here's more studies. Adverse events is why I put this up here, okay? These had more elite recreational athletes that were involved, median age a little bit younger, mid-20s, and again, looked at a whole 8 studies. So essentially, the adverse events were 5 studies, total 35. There were 2 hardware removals, et cetera. And those who were conservatively treated, 39 treatment failures, okay? So again, they were comparing to surgery, no surgery. Now, if we look at case series, navicular stress fracture, only 18% non-weight bearing for 6 weeks, okay? 55% returned to sports fully, only 18% non-weight bearing. 3 had normal imaging and follow-up. So if we look at these studies, these are done, and I only bring these up to take a look. That sometimes is not really clear-cut, okay? Not really clear-cut in terms of the management, but you really have to make sure that you have a good diagnosis and that when you're following them, and they followed them for 3.7 years, and this is a long-term study that was done, taking a look at fractures versus stress reactions, which is not as bad. These 67% returned to sports fully, and they developed radiological features, though, of a stress fracture. So despite this, you have to follow it up to see how they're doing from that perspective. Now, let's move on for a summary then. In all these studies that we've talked about, which some are pretty good, some are just retrospective, but non-weight bearing for at least 6 weeks is still regarded as a standard of care for non-displaced navicular stress fractures. There's no clear demonstrated advantage for surgical treatment over non-weight bearing for 6 weeks, and it's very clear that limited weight bearing is tolerated. Yeah, you can put some weight on it in your walking boot or use crutches, or you don't have to use crutches. It's inferior to either non-weight bearing or surgery. So what are our additional questions? If that athlete with end spot pain, that navicular pain, is there increased risk of other injuries if that athlete is allowed to continue playing? So if you're an athlete who came in who wants to run, but then is told, sure, you know what? You've got this stress fracture, go in a boot for most of the day, and then when you want to train, come out of the boot. Is there additional injury risks? Are they going to lose proprioception? Are they going to get weaker? Their calf going to get smaller? And there needs to be some randomized controlled trials needed comparing non-weight bearing as well with a cast versus non-weight bearing with a cam. How many people want to wear a cast for 6 weeks versus wearing a cam boot if you had a choice? Right? So that'd be a great study. You know, compliance is key though for that, right? Compliance is key. And what about navicular stress fractures in kids? So I belong to a sports docs Google group, and I put this out there to my colleagues across the country and some international colleagues as well. I have an 11-and-a-half-year-old male basketball phenom. They all are. MRI shows edema and navicular with an incomplete fracture line. Negative plane films. How would you manage? Okay, there you go. And you can see these scans. 11-and-a-half-year-old. So these are my responses, and these are physicians that are dealing with elite athletes all the time. Get a CT, look for sclerosis. If there's no sclerosis, would treat non-weight bearing in a boot. Now, let me tell you what sclerosis means. Sclerosis means that there's that fracture isn't healing, okay? That this has been going on for a long time, and if sclerotic lines adjacent, then there's a less chance that it'll heal, and they're going to need surgery and scrape it out and put a bone graft. Assuming no sclerosis, would treat non-weight bearing in a boot for 2 weeks, progressing to weight bearing as non-painful. Total boot time 6 to 12 weeks. Okay. Case report in a 13-year-old female, treated 6 weeks non-weight bearing in a cast, which is what we talked about. 4 weeks weight bearing in a boot, semi-rigid orthotics, CT scan 5 months after diagnosis. Overall, you need to take a very slow progression back to sport. This is my friend, Steve Simons. I talked to a pediatric sports ortho specialist. Returned to play 12 weeks. Here's the parent. I'm leaning towards letting him progress as fast as his body tells him since he has no pain. I just really lean to letting him go more aggressive and listening to his body. 11-and-a-half-year-old. He's trusting in his 11-and-a-half-year-old. Okay, so what do I do? Right? This is what I did. 2 weeks non-weight bearing in a cast. I originally planned 4, but I did 2. Then 2 weeks non-weight bearing in a cam boot. Remember that study I mentioned earlier that we should do? So he could take it off, start physical therapy, and keep his calf strong. Then 1 week partial weight bearing in the cam boot, then full weight bearing in the cam. On CT scan at 6 weeks, there was sclerosis, but this is the good sclerosis indicating healing, okay? The sclerotic healing, do you see that there? Okay? Transition out of the cam boot over 2 weeks. We got him custom orthotics. started transition back to practice at 13 weeks from the date of diagnosis, although his mechanics were still faulty. He wasn't strong still. And symmetrical in all functional testing by 17 weeks. So the answer was probably back to activity about 12 weeks, but really he wasn't ready to go till now, but he started playing that time. All right, last case. At 13 weeks? Yeah. Practicing with this team. Okay. Yeah. Well, yes, competitively. Believe me, you only have so much control, right? All right, third case, ankle injury. Unknown age, unknown level of play, soccer athlete, first game of the season, was kicked in the back of the ankle, stumbled and fell. Teammates heard a pop before the fall, and the athlete needed assistance getting off the field. Who was the most likely injury based on this history? Here's a big sigh in the front row. Why was there a big sigh? Yay. 94% of you correct. Okay, so when you have an ankle injury like this and you have a history like this, right? Someone kicked me, a stone hit the back of my calf, when really people say, dude, no one's around you, right? So you do this something called Simmons triad. You first always look at the angle of declination. You have them prone, and what you're going to do is you're going to see what's happening here. This is normal. Your normal ankle is going to have a little bit of plantar flexion, but this one is not plantar flex. So you know that you want to look at the ankle declination. You can palpate a gap, and then you do the Thompson test, where you squeeze the calf and you make sure there's plantar flexion response to that, okay? Now, how do you manage acute Achilles tendon rupture? Meta-analysis, I'm going to just go through this really quickly, but a re-rupture rate after surgery is 3.6% in this Amendola study compared to non-operative. And this is what we've always learned, is that if you have surgery, your re-rupture rate is lower. But complications are certainly higher in your surgery group. Deep infections, the scars, some people may keloid, sometimes the sural nerve is caught, and so they have sensory complaints. The DVT rate is actually not statistically significant, but anytime you mobilize, you're going to increase your risk of a DVT. And the time to return to work was no difference, but these weren't athletes. Okay? This is a meta-analysis and systematic review of operative versus non-operative by Ochin, and actually, these numbers weren't so different. Re-rupture rate, not so different. Other complications rate, higher in the operative group. But if you look at functional outcome, short and long term, return to sport for those who were sporters, and return to work, no significant difference. Okay? So, now what? This is a great randomized control trial that Lanto did. Looked at 60 patients, majority of men, and look at the age. None of them were competitive athletes, as defined by them. Non-surgical, this was what they did. They put them in a maximum plantar flexion, that equinus in a cast, non-weight bearing for a week, then put them in this dynamic vacuum orthosis. And this thing is pretty cool, but essentially, there's a couple different brands out there, but essentially it customizes the amount of plantar flexion, the amount of heel, right, and gradually lowers it. And it has also a control back here to control that degrees of plantar flexion. And then essentially you can read that. Basically, at 30 degrees, weeks 2 to 3, 15 degrees, weeks 4 to 5, starts to allow them to have free movement, and after week 7, you're in shoes. Surgery repair was done within a week of injury, and this is how they managed them. In a cast for 1 week non-weight bearing, and then a similar rehab program as above. And this was their rehab program in this study. And this is in your, you'll be able to access this, but this is their exercise program that they did, weeks 8 to 10, and then you progress weeks 11 to 1 year over 2 months, and this was the exercise program. And in this group, they were allowed to jog at 3 months, and they could cycle and swim as well. Prior to that, sports with sudden acceleration and jumping was only allowed after 6 months. None of these had formal PT, they were on their own. 18-month follow-up, surgical, better results in functional health and well-being. But there was no difference in some of the other things they looked at. You know, could you wear heels? What's your subjective calf muscle weakness? But when they measured their calf muscle strength, there was definitely a difference between the groups. Operative treatment, better strength at 6 months and 18 months. But both techniques failed to make that injured side equal to the uninjured side, okay? But if you compared surgery versus no surgery, there definitely was a strength difference. What's the summary of this data to me? Re-rupture rate after surgery is less, still less than with non-operative management. Complications are certainly higher in the surgical group. And for those elite athletes, competitive athletes, 13-year-old semi-pro athlete, who are more powerful and explosive sporting activities, surgical intervention to gain as much calf strength as possible may be recommended. What about kids? Only case reports. Really, there's only case reports that weren't avulsions, because most of the time with pediatric population, you're going to have an avulsion of the Achilles off the calcaneus. There's a 7-year-old with an acute rupture after landing on a dorsiflex ankle, treated non-op. 10-year-old ice skater, missed partial laceration, that then totally ruptured. That wasn't really, there was a reason why there was a rupture. And then there's a case report and review of literature of lacerations, but really nothing that much in terms of Achilles tendon ruptures. So shared decision-making. I participated in a lot of shared decision-making with the dad of this 11-and-a-half-year-old phenom, right, with the navicular stress fracture. But understand that both the patient and the family and the healthcare provider, and usually in an elite athlete, it's the agent, right? So that's a whole different world there. But they're involved in decision-making. Both the patient and their circle of support and the healthcare provider exchange information. They both indicate their preferences regarding diagnostic methods and treatments, and they both agree with the final decision. This is shared decision-making. Now, before I take questions, Aaron Rodgers was an athlete at UC Berkeley, but here he is in his Green Bay Packers uniform. He fractured his clavicle, mid-clavicular fracture. 4 days later had surgery, returned to play in 9 weeks, okay? Yao Ming, he had a diagnosis of a navicular stress fracture. Basically told him that he'll miss about 8 to 12 weeks. And in 7 weeks they did a CT scan, he wasn't healing. So they did surgery in July. So that's about May, June, July, 2 months later. By the fall, so from July to September, October, he was playing by then, sprained his ankle, then had another stress fracture, and it ended his career. And Kobe Bryant, this was in 2012 at the London Games. A year later, he tore his Achilles. He had surgery the next day. How long would you say before he went back to his first game, if you guys had to guess? 8 months. 8 months before his first game, okay? So I have time for questions. And this slide is up, and I know it's been floating around. I'm course chair director of this conference that we're going to have. If you're interested more in pediatric sports injuries or exercise injuries, our topic is managing pain. And it's going to go from medication to splinting and casting, et cetera. So it's a whole range of topics, and it's at the Memorial Stadium on Saturday, January the 11th, one-day conference. So join us, and there's some brochures outside. Okay, I have some time for questions.